think we can start. Good evening, everyone. On behalf of the Lancet Commission on Reimagining India's Health System, the Center for Policy Research and the Population Foundation of India, it's an absolute privilege for me to welcome all of you to what promises to be an extremely exciting, insightful, and extremely critical webinar that we are hosting today. The Commission itself, a few words about the Commission, is an ambitious cross-sectoral endeavor that aims to lay out a citizen's roadmap for achieving the somewhat elusive goal in the Indian context of universal health coverage for the people of India. It is a comprehensive research effort that aims to bring together key stakeholders from across the social spectrum. The Commission, as part of its activities, has started this monthly webinar series, of which today's webinar is one such. It is an attempt to build a platform that brings together academics, practitioners, and the public to engage in an evidence-based, sober, but rigorous dialogue on public health in India, and with the objective of addressing critical issues regarding charting a pathway towards the goal of universal health coverage. Today's webinar is specifically focusing on the union budget that was announced on the 1st of February 2022. This is the Government of India's second budget presented amidst the backdrop of the pandemic. The first budget that was presented last year in February 2021 was presented in the hope that the worst of the pandemic was behind us. This budget too was presented amidst the third wave, but with fingers tightly crossed that we have passed the worst. And we felt that this was an important moment, therefore, for us to understand, unpack, evaluate, and debate the extent to which the learnings from the pandemic and the ravages from the pandemic of these last 2 years have played into shaping and reshaping health policy and public investments in health. And more importantly, to use the budget as a starting point for a broader discussion on one of the most critical tensions that public policymakers have to confront, the tensions between investing in physical infrastructure, creating conditions for private investment to facilitate and enable an environment for growth, versus investing in human capital, also with the objective of creating and enabling an overall environment for growth. How do we balance both needs in an economy that has been ravaged by the pandemic? And how do we build forward towards a more inclusive, equitable, and universal health system? These are some of the issues that we hope to discuss today with our panelists. It's a real pleasure and privilege for all of us who are hosting today's seminar to have brought together such an important group of people who, from different perspectives and different roles, have both been thinking about critical questions of health policy, have contributed to budget making for health, and continue to engage, challenge, and build an environment for prioritizing health in public policy making and in public investment. So joining us today is Professor K. Srinath Reddy, who is the president of the Public Health Foundation and formerly headed the Department of Cardiology at the All India Institute of Medical Sciences. He is the first Indian to be elected at the National Academy of Medicine, USA, and has been awarded several prestigious international and national doctorates and fellowships. Dr. Reddy is a very important voice in debates on public health in India. And in the run-up to budgets and on budget day, a very, very important voice, both presenting what public health debates are hoping for from the budget, and then discussing the extent to which that hope was fulfilled or not in the budget. So thank you very much, Professor Reddy, for joining us today, and really looking forward to hearing more from you. Along with Professor Reddy, we have with us Dr. Amarjeet Sinha, who from amongst the biradri of bureaucracy is perhaps the most well-known voice speaking on matters that really are relevant to all Indians. So, his career has spanned critical arenas of rural development, of health and education. And he has been secretary both at the state and government of India in all of these areas. And it's very rare, if I may say, to find IAS officers who covet these positions. And Dr. Amarjeet Sinha is one of those who recognizes that the future of India lies in investing in the people of India and has been at the helm of shaping policy and implementing policy on these issues. Looking forward to hearing from you both on this budget, but also keen to hear from you a broader trajectory of the evolution of education and health policy in India. And we have also with us Ms. Avani Kapur, my colleague, a partner in crime, if I may say so, a fellow at the Center for Policy Research and lead of the Center's Accountability Initiative. The Accountability Initiative has been tracking social sector budgets for now nearly 14 years. In fact, Avani has led this work for many years, and just today I got the printed versions of the 14th edition of our budget briefs, which is an annual exercise at collecting, analyzing, and understanding both fiscal allocations, but also what happens after funds are allocated as they travel through the labyrinth of the bureaucracy to reach where it should, what reached, when did it reach, how did it get spent. These are some of the critical issues that Avani and her team have been, at Accountability Initiative, have been looking at and studying. And I don't think there's anybody in this country who knows as much about the minutiae of the complexities of public expenditure in social policy, and particularly on health, as Avani. So she will be able to give us a really good sense of what's actually happening on the ground and what needs to be done to be able to enable better, more efficient, and more accountable expenditures for health. So thank you all for joining us. I'm really looking forward to this conversation today. Professor Reddy, if I can start with you, just to begin with, to give us a broad sense of what your expectations were from this budget. You wrote in many newspapers with a lot of hope that we would see significant investments across the entire spectrum of different aspects of India's health system, primary care to tertiary, and most importantly, investments in core public health. So where do you think are the big gaps, and which elements of those gaps did this budget actually fulfill, if any? Over to you.
Thank you very much. So let me start with some disclaimers. I'm neither an erudite economist nor an experienced civil servant. And I do not speak on behalf of the Lancet Commission. I do not speak on behalf of the Public Health Foundation of India. I speak as a public health advocate. And as a public health advocate, it's often our fate to be like Oliver Twist, saying, please, sir, I want some more. In this case, please, madam, could we have some more? So we do keep asking more for health. And I suppose the expectations were also based on the experience of the pandemic, having told us that unless we have an efficient, equitable, and empathetic health system, we are unlikely to create the surge response needed for a swift and strong response to a public health emergency. Also, I believe that beyond what we learned from the pandemic itself, there is an abiding commitment to the Sustainable Development Goals, and especially to universal health coverage, which you said is elusive. Yes, elusive, but not illusory. We do have a commitment and we must reach that. Then, of course, the National Health Policy of 2017, which has given us a charter. So given all of these, I believe that apart from addressing the immediate priorities of coping with the pandemic in terms of its residual effects, as well as preparing for a potential resurgence of a pandemic, though that probability does not appear to be as high in India at the moment, but also paving the way for building the health system towards meeting our commitments to universal health coverage and the Sustainable Development Goals. But in that context, the budget overall was disappointing from the point of view of not providing enough for health and not necessarily prioritizing within what was allocated for what I believe is absolutely critical, which is a strong primary healthcare system supported by good secondary healthcare, but run with a very well-trained, multi-layered, multi-skilled health workforce. The budget gave about 16% over the budgetary estimates of 21-22 of the past year to health. But when you actually look at the revised estimates, the increase was only 0.6%. And if you look at as a percentage of the total budget, the health component was 2.26%, which is a slight decline over the past few years. And compared to what the Ministry of Health has been asking for the past 2 years, only 69 to 73% has been allocated. Now, it could be said that the ministry may not have utilized all of the monies that have been allocated. And we have seen what has happened in the allocation to Pradhan Mantri Jan Arogya Yojana, where out of 6,400 crores, only 3,200 crores was spent. And we know the reasons why, and we can allude to that. Now, but there are a number of other reasons why also there is an underspend. If you do not have adequate infrastructure, but also if you do not have adequate human resources for health, then you are unlikely to have that absorptive capacity. But given the ambition that we have shown of comprehensive primary health care, of saying that we will at the health and wellness centers dispense drugs, provide essential diagnostic services, and that means employing lab staff as well, and expand public health laboratories right from the block level to national institutes, a whole chain of laboratories, and that requires its own complement of skilled health workforce. Given that level of ambition, I thought we would certainly see an increase in the allocation to health, and particularly into the areas of primary health care and human resources. So what did it deliver? It provided a great deal of emphasis on capital expenditure. And I believe that capital expenditure was being seen as an important lever for accelerated economic growth. It does create certain jobs as well, but the whole area of human resources for health, where we could have actually invested in a much larger health workforce, particularly at the front lines, maybe doubling the number of our ASHAs and auxiliary nurse midwives, and making sure our front lines were very well staffed with digitally enabled and reasonably well compensated frontline workers. That particular opportunity seems to have been missed. Then in terms of secondary care, we have not seen much attention being given, at least explicitly, to the whole area of district hospitals. I believe it may be part and parcel of the health infrastructure mission, but apart from the infrastructure itself, we require a huge number of human resources there. And why is it that we have not seen a very clear-cut reference to district hospital strengthening and a linkage to primary health care? Then in terms of the budget speech, the Honorable Finance Minister has given a good indication that there will be an open platform for a national digital ecosystem, which is very welcome, that there would be a national tele-mental health program, which is again very welcome, but there were no allocations in the budget for that. But again, even mental health has to be definitely seen as something that has to be delivered at the community level, and it requires, again, a very good primary health workforce, and not necessarily only through telemedicine services. But while this is certainly most welcome initiative, but I believe primary health care too should be entrusted with the task of the broader mental health agenda, apart from other non-communicable diseases. In terms of infrastructure, the infrastructure mission has been allocated 5,846 crores, which is very good. But given the fact that the mission is supposed to be expending 64,120 crores in 6 years, and the mission started in last October, are we really hoping that we will be able to spend as much, or is this only the initial year and we expect to build in the future? We'll have to wait and see. The National Digital Health Mission has promised as much, but the allocation has been 200 crores. I would have expected a greater ambition for the National Digital Health Mission. But again, we'll have to see whether this is only the initial step and there will be a greater increase in the resources later on. The Pradhan Mantri, the PMSSY program, Swasthya Suraksha Yojana, which principally focuses on tertiary care, that has received 48% increase. Again, the chasing All India Institute of Medical Sciences in every single state appears to be wonderful from the point of view of visible tertiary care institutions. But unless you have strong primary and secondary care, mere investing in tertiary care is not going to meet our health system objectives. Therefore, absence of detailing on what is being dealt with for district hospitals is particularly a sense of concern. But perhaps it is going to be part and parcel of the health infrastructure mission. But apart from the capital expenditure for the infrastructure, we do need also definitely human resources. The Pradhan Mantri Jan Arogya Yojana has received 100% over the actual revised estimates, and it shows not only the fact that non-COVID related care was suffered for a variety of reasons during the COVID period, but also the lack of penetration into the second tier and third tier urban areas as well as in the rural areas, and the lack of adequate linkage with the National Health Mission is actually costing the Pradhan Mantri Jan Arogya Yojana in terms of outreach and efficiency. What did it not deliver? And here my concern is mainly on the National Health Mission. As a percentage of the total health budget, it came down, while actually the increase was 7.4%. As a percentage of the total health budget, it came down from 48% in the past year to 42%. Now, why does this matter? The 15th Finance Commission, as well as the National Health Policy of 2017, say that 67% of the health budget should actually go to primary care. And National Health Mission is the major vehicle for primary care, apart from all the national health programs that are being delivered. So why is it that the National Health Mission is still being under-resourced? And where is the funding clearly indicated for the local bodies? Again, the 15th Finance Commission, as well as the Finance Minister's speech of 2021, of past year, talked about allocation for primary care going directly to panchayats and municipal corporations and urban and rural local bodies. That is not very clear. Perhaps the Health Ministry will tell us how it's going to happen, whether it's going to happen through the National Health Mission or through the Health Infrastructure Mission. We'll have to wait and see. In terms of the health workforce itself, while the National Health Mission shows an increase from 4,800 crores to 7,500 crores, that's inadequate considering the huge amount of requirement that we have. There are 63% vacancies even for specialists at community health centers, but much more so in terms of the ambition to build a large number of health and wellness centers, including lab staff there. We do require a much greater investment in human resources. The Department of Health Research has shown only a 3.9% increase, which I believe is probably less than optimal, because given the huge research agenda that we have, not only pushed by COVID, but also many other health conditions that require much greater implementation research apart from other elucidatory research. I believe COVID services, vaccines have received 5,000 crores, and perhaps that may be enough and may get a supplementary budget later on. But it appears that the COVID services themselves have not been given any allocation, perhaps in the belief that Omicron is going to be the end of the COVID story for us. Or if there is a resurgence in a more virulent virus, perhaps there will be a special package later on. I believe that there ought to have been a much greater investment in human resources for health. This morning's report in print that we are planning to import nurses from abroad and also train our nurses for export including in training people from Northeast in the Japanese language. This suggests to me that while we must indeed ensure that we have adequate number of nurses, looking at market mechanisms for this without investing strongly in building up our own capacity for human resource development, especially by elevating our district hospitals to become educational centers for new medical colleges, new nursing colleges, and allied health professionals. That, I believe, is not going to, if we fail to take that step, our human resource scenario will not continue to, will not improve as much as we want it to. So my submission finally is, yes, there are good elements in the budget. There are good moves that are being made to strengthen different components of the health system, but I do not find a unified structure for universal health coverage, which provides comprehensive primary care with continuity of care and connected care to secondary and tertiary levels in a bidirectional manner. What we need is a combination of infrastructure, human resources for health, and digital technologies, but connected in a coherent manner. And it is this connect that is missing. And unless we also ensure that the states are stepping up and they are also becoming part and parcel of this whole plan, they step up their own finances. But unless the center invests in many of these elements to push towards that coherent connected plan, we are not going to see that. For example, even in terms of investing in public health capacity, public health expertise, creation of public health cadres has not happened in most states. And unless the center actually starts incentivizing through its own national programs, the creation of public health cadres, that's not going to happen in most states. Right now, you only have in Tamil Nadu and Odisha, really speaking. So there are many areas where the budget could have actually acted as a catalyst for transformation of our health system towards a much more cohesive and connected health system, which is capable of becoming a competent vehicle for universal health coverage. I believe we have taken some steps, but there have also been some missed opportunities. Finally, I would like to say, since we have expanded the definition of health and have included many other elements, the budget does signal very good initiatives for drinking water, providing much greater drinking water assurance, investing more in affordable housing, providing connected tele-educational services, and important measures to reduce air pollution. These are all absolutely essential, but within the health sector itself, I believe we ought to have taken more definitive steps to strengthen the public sector as a vehicle for universal health coverage. Thank you very much.
Thank you. Thank you so much, Professor Reddy, for that absolutely masterful, very, very detailed and important overview of what the budget did and did not do for the health sector. And I think that you've highlighted some of the critical contestations that I hope we can dive into in a little more depth through the course of our discussion today. One level, the challenge between, in a world of limited resources, the challenge between the need to invest in capital expenditure, the need to invest in physical infrastructure to crowd in private investment and generate jobs on the one hand, with the need to invest in human capital, because ultimately productivity and growth are deeply interlinked with human capital. How do we balance this out, and to what extent have we been able to do so? You've highlighted the need for a comprehensive, connected health system, the need to ensure that we are investing across all elements of the health system, the critical challenge of center-state relations, the urgency of human resources, of creating public health cadres, something I feel we do not discuss enough in our debates, and the role of local bodies, all of which I hope we'll be talking about through the course of today's discussion. Dr. Sinha, may I turn to you, of course, for your opening comments on the budget and where and how you see the sort of signaling from the investments that have been made. But I would also request you to give some of your insights in from a somewhat more historical perspective, how the health how health policy has evolved, particularly from 2004-5 with the National Health Mission, of which you were such a critical part of making and shaping, and how the pulls and pressures around budget making have been negotiated over the course of these 15, 20 years. Because after all, in some ways, the challenge of the tensions that this budget presents, the tensions of capital expenditure versus revenue expenditure in a world of limited resources, isn't new. It's perhaps a little bit more heightened because of COVID and what it's done to the economy. But it's always been there, and we've always grappled with how to think about growth with private investment and big GDP numbers, or growth that genuinely invests in human capital. So your thoughts on that too would help kick us off, and your provocations there will help shape some of our conversation today. Over to you.
Thank you. Thank you. One, of course, masterly presentation by Dr. Reddy, covering the entire set of issues that we were to discuss today. So he makes my job very easy, because I'll not repeat what he's already said, but a few of the insights that I wanted to share. One, of course, it's a lot of people have this question that how come the health system, where funding has been a concern, a matter of the public financing, how it is able to, with the spread that it has, provide for 170 crore vaccination shots. I think this is indicative of the challenges as also the kind of possibilities. One, financing, yes. In fact, the national health policy that Dr. Reddy referred to has very categorically mentioned about the 2.5% GDP, as also by 2025. It is also the other point, which was not earlier, was that state governments will also increase their health spend to 8% of the budget. Now, financing and governance has to go together. As has been pointed out in the opening remarks also, in the CGA's report quoted today, there are many a time instances of monies being released but not utilized. So one, we need to improve the efficiency of our system. Two, we also need more finances to provide the kind of care that is needed. Now, the lessons from COVID, what comes out very clearly, there is no substitute to a well-funded and functional public system, especially when it comes to public health challenges and primary care. There is also a possibility of partnerships. And again, something which is very striking, say the testing capacity, just as one example, how the augmentation of the testing capacity happened during the COVID period, how on a very large scale, the private sector could also be mobilized to join the capacities for testing. The third category is the development of vaccines. The proactive role of the scientific institutions, the Department of Biotechnology and others, also indicate many possibilities in terms of government and the private sector actually working together towards public health goals. Something again which was part of the National Health Policy 2017 to orient the private sector also to public health goals. The Finance Commission's report, which was referred to, decentralization, very rightly pointed out. What is coming out very clearly, and again, I often refer to a remark of Dr. Reddy's in one of his articles, that every minister is a health minister. Where health ends and some other department begins, it's very difficult to make that distinction. That being the case, the whole of government approach, which again has been attempted in the coverage for vaccines and in many other initiatives, I think we need to bear this in mind, that there is no going away from a communitized approach and a whole of government approach. And from that point of view, the Finance Commission recommendations, already a fairly large sum is available in a decentralized manner. The Ayushman Bharat Infrastructure Mission, again, is identified, for example, the urban primary care as a gap. and a lot of investments are in urban primary care. Like identified critical care gaps at district and sub-district level, a point that Dr. Reddy was also alluding to. So in terms of the focus of the Ayushman Bharat infrastructure mission, public health mission, the thrust clearly is on filling some of these gaps. Likewise, the capacity for testing for public health labs at local levels. Now, I think a lot of these capacities, part of the mission that was announced in October, work has been rolled out, and over time, hopefully, this will lead to far better availability of services. The point on human resources has been highlighted, and again, the continuum of human resources that health needs. While many efforts have gone into change in regulations to increase the postgraduate seats or to increase the MBBS intake, there is still a long way to go for the large requirement of paramedic, nursing, and other services. More than the actual certification, what is a challenge is the quality of those coming out of these systems in a manner that they are employable and they are fully geared to meet the needs. Some effort at upskilling, even those already there. For example, the ASHA started as a community worker, but many of the ASHAs, through a very systematic training program, are today community health workers. Some of them, a few of them, in some states, were also encouraged to join A&M, GNM, and staff nurse programs. As a consequence, some system where you nurture human resources and provide opportunities for a continuum of upskilling of skills for proven of individuals who have already proven their ability to provide for the system. Now, for all this, the capacity for, while private sector can set up nursing institutions, paramedic institutions, the regulation, some efforts at improving it in the medical education side also we have seen, the National Commission, and also in terms of the other sectors, the Nursing Council and so on. So overall, the sense one gets is, at the end of the day, health is a state subject, medical education is a concurrent subject, and the central government's instrumentality is needed because the experience with the health mission also has been that wherever Government of India also steps in with resources, in return demanding some reforms in the system and allowing for a longer term perspective on sustainable human resources. That's important because for filling up vacancies, for adding human resources to the system, that's where many of these programs provide an opportunity. Infrastructure creation, yes, starting with the health systems projects in the past. But when you travel across the states, you will still find there is a lot of, while there is a lot of overloading in many infrastructure and hospitals where you need more infrastructure, there are also instances of buildings being there, but not equipped to provide the services that can be provided from that particular facility. So both challenges are there of additional infrastructure as also of human resources and services in many places where the buildings have come up, equipment has come, but adequate human resources are still not available. It's a very complex sector, but I think on the wider determinants of health, as Dr. Reddy mentioned, the investments in drinking water, in housing, in sanitation, all these augur very well, even in urban areas, because clearly a lot of the disease burden can be influenced by what happens here. Likewise, the decentralization, which is the intent of the Finance Commission, devolution and grants, that needs to be pushed very, very strongly. Urban areas also, we need at the Basti level or at the ward level or below a ward level, an active community engagement in health services, because clearly at the point of delivery, unless and until it's a communitized approach, it's a people's health in people's hands approach, there are challenges to where we will reach. Yes, for doing all this, resources will be a challenge. Improving governance improving utilization, improving efficiency, decentralizing, getting value for money in terms of the investments being made, monitoring systems and quality of services, facilitating partnerships for public health goals at various levels, in expanding capacity for public health functions, because clearly what comes out very clearly, public health functions need public systems, credible public systems. And I think across the country, there are many instances and examples across states which have invested in building up a public health system and how that stands them in good stead in times of need. So I think overall, the lot of the gaps filling the secondary and tertiary sector, for example, the PMJ, the intent clearly is that up to 5 lakhs for all these households who are deprived, can we provide them an assured guarantee? The challenge again has been, while the guarantee is available to those households, in many places, the households are still not fully aware of their entitlements. Linking households to health facilities has been a challenge. That's where the digital health mission and a lot of efforts therein, of course, facilitated, because technology is a means. Ultimately, that has to be facilitated by some community interface. So secondary, tertiary care, if access to secondary and tertiary care can improve through these processes, as also, as I mentioned, we have to see the totality of the health system. We'll have to see the totality and the interconnectedness of the wider determinants, decentralization as a thrust, human resources and quality and excellence as a thrust, and equally important, the financing issue, which clearly here's a sector. And by and large, the experience in government is that if a sector starts utilizing fully the funds available to it, it is considered for higher allocations at times of need. Because I think this is where, clearly we do need, and again, I think a lot of the development journey, a lot of the growth journey needs human development. We need to move up much faster on the human development index as well. And for doing all this, strengthening health and education services, and as far as policy is concerned, there has been a move forward over the decades. The 2017 policy for health, or the 2021, the National Education Policy, clearly they are charting new courses and new ways of doing things, and trying to ensure quality learning as also quality health services. Many of the requirements of financing, partnerships, as also better governance, efficiency, and decentralization have to go hand in hand. And it is hoped that in years to come, we will build more capacity for better to health services to every Indian household, wherever they may be residing. And I think for doing all this, the basic frameworks, policies, programs are in place. And again, as I said, the allocation of resources is also a function of the utilization of resources and its effectiveness. And many programs which capture the attention of people, drinking water, for example, housing, for example, and which is also a very basic need, which have quite a major implication even in terms of the health and care. Clearly, resources are made available. And I'm sure over time, with a lot of the thrust on infrastructure, with better incomes perhaps, with better employment opportunities because of infrastructure, it may well be possible over time. There are challenges, and I recognize those challenges. Higher financing is a requirement, but the good thing is that during the vaccination, especially, as also the testing capacities, even in terms of ramping up, for example, public health, emergency health funds made available at various points of time, small little changes in terms of ICU beds, in terms of oxygen availability. So the critical gap filling has been the priority. Because naturally, when the resources are limited, you begin with the critical gap filling, and then you move on to establishing the system in its entirety. Clearly, even that journey is equally important. And I think it it's important that the lessons from COVID in terms of capacities, in terms of total public health trust, in terms of public investments, move in a direction that actually resolves challenges for the future as well and makes communities better prepared to monitor their own health so that people's health is actually in people's hands. Thank you.
Thank you. Thank you so much. You raised some very, very critical issues, particularly making that very crucial link between financing and governance, highlighting the importance of a community-based approach, the centrality of decentralization. And I hope we can discuss that a little bit more in our in the next round. And also, I think, one of the lessons that we might that the sort of the vaccination experience also highlights is, in fact, we do have good governance and good state capacity on some things when we go into mission mode. What is it about this health system that it fails to do so in its everyday? And it's not just about health. This has been a puzzle for me across many different social sectors. And for that matter, even our ability to get a good physical infrastructure going. The Indian state seems to be able to mobilize itself to do big elections and vaccinations, but on the routine every day, somehow that mission doesn't convert into fast capacity and efficient delivery. But I hope we can discuss some of this through the course of the next round. Ms. Kapur, let me turn to you. We've, I think in some ways, Dr. Sinha sort of framed the challenge of financing and governance. You have been looking at what happens from the point at which a ministry presents its demand for grants to the finance minister, to the finance ministry, and as Professor Reddy highlighted, only somewhere between 69 to 73% of what was asked for has been allocated to the Ministry of Health and Family Welfare. This is not a new phenomenon; it's an old one. And you've also looked at what happens when money goes from the central government coffers to states, to districts, and finally to their points of expenditure. So how does this link between financing and governance unfold? But before that, at all, since you've really dived into the nitty-gritties of our budgets, if you look back at these 2 years when health expenditure was certainly priority, how has the health budget changed, even within its own limits? So what were the resource allocation dynamics across COVID emergency care, tertiary care? How did the PMGAY sort of respond to the COVID crisis, where tertiary care was, was significant? What happened to non-COVID related expenditure? Have we seen changes in priorities? If you could give us a little bit of a sense, taking this 2-year horizon, and then talk to us a little bit about that financing and governance link, that'll be wonderful. Over to you.
Thanks, Yamini. I always start with this caveat because every time I'm discussing the union budget and health, someone will say, but health is a state subject. So I wanted to start with some numbers. As per the 5th National Family Health Survey, if you're a girl born in Bihar, the chances are that 57 out of 1,000 of you don't make it to your 5th birthday. On the other hand, if you're a girl born in Kerala, well, 7 girls out of 1,000 don't make it to their 5th birthday. And I'm sorry to start with such depressing numbers on a Thursday evening, but I think it is important when we discuss the center state of who should be funding health. I think there is a set of minimum standards that are required for any country so that every citizen, irrespective of where they live, have the rights to adequate healthcare. And so I think one of the expectations that I had in this year's budget was actually to address these important questions, especially as Yamini said, we're coming in the backs of a COVID crisis. And unlike before, the last couple of years, we've actually had a lot of mobilization of resources available specifically for health. So in March 2021, the cabinet approved this Pradhan Mantri Swasthya Suraksha Nidhi. It's a single non-lapsable reserve fund where the proceeds of the 4% health and education cess that's been in place since 2018-19 are going into this fund. And as per the cabinet order, it's going to be this cess money that is going to be used to fund NHM. It's going to be used to fund Ayushman Bharat, including both the health and wellness centers and the Pradhan Mantri Jan Arogya Yojana. At the same time, we also saw that there was a lot of investments by international agencies, especially during the COVID crisis. So a lot of the COVID emergency package that was announced, a lot of the money was coming from international sources as well. And then, of course, the 15th Finance Commission that both Professor Reddy and Mr. Sinha spoke about, a little over 13,000 crores last year, was allocated a little over 13,000 crores this year as well. And in November, this last year, 2021, 19 states got totally about 8,000 crores released for health to local bodies. So in some ways, you got different sources of funds that previously weren't available to you, or at least you had those available right now. So I was surprised in some ways with the health budget, because I think the two questions that we're always asking ourselves, both at Accountability Initiative, but looking at any social sector program as well, are you spending enough, and are you spending it well and on the right things, which ties back to what Dr. Sinha said in terms of unutilized funds. And unfortunately, the answer to both these questions, at least in this year's health budget, seems to be not really. I think going back to the fact that health requires investments by both the center and states, I think it's very clear. And again, the economic survey was really depressing. It came out just before the budget, which showed that in 2019, this is just prior to the pandemic, we were, as a share of the GDP, we were spending the same as we were in 2015-16. In fact, in 1920 was even lower than the previous year. And again, even if you look at it as a share of total expenditure, which can in some ways show, it can be a proxy for prioritization. Again, 2019, same as 2016-17. In fact, the revised estimates for 2021, where we've, like I said, we've seen additional resources, the proportions of total expenditure were the same as in 17-18. And that is, again, really confusing. This year's budget saw only a 200 crore increase, and I won't repeat some of the points that Professor Reddy detailed out very comprehensively. But what we were trying to understand in some ways is, where is this money going, and where is the money being decreased? And again, this is where it gets depressing. Professor Reddy spoke about the fact that the National Health Mission, which has been such an important priority, so 7% increase. But again, the allocations were lower than the actual money spent in 2021. But if you look at the breakup of the national health budget, you can see big cuts in things like the reproductive child healthcare. It fell by 9%. You can see a 17% decrease in allocations for communicable diseases. Even health system strengthening, which has been a big focus and at least a lot of talk around it, it fell by 3%. And as we know, the National Health Mission is an important form of non-wage funds to states. And we also know that the pandemic hit a number of services, whether it was antenatal care, inpatient treatment, even treatment of serious communicable diseases. We did see this big drop in terms of people accessing especially during the lockdown, but even a little bit afterwards. So some boost again to resume these services, but more importantly, prioritize them. I was hoping a little bit for that. At the same time, I think the Pradhan Mantri Jan Arogya Yojana, which is, so you have the primary healthcare service to some degree by the National Health Mission, and then you have the tertiary healthcare to some degree serviced by the JAY. I've always found it extremely confusing. Yes, there isn't enough awareness about the scheme, but even in terms of the budgets, I don't think that the commitment right now is fully there. A study that was done by IG estimated about 28,000 crores, and it could go up to even 70,000 crores was what would be needed to be able to actually reach every intended person. We've been allocating 6,400 crores pretty much consistently year on year, and every year the revised estimates are around half of that. So what's happening? Is it that people are not claiming enough, or is it sometimes that catch-22 where because you don't have enough money, you're kind of rationalizing, you're not really going all out because you don't want everyone to claim. So I wish that there are more studies around that, because that's a puzzle that we've also not been fully able to solve. One of the major reductions this year in the budget was the money allocated for the COVID emergency response and health system preparedness. Again, a bit of a puzzle. I think that, as you said, Yamini, that this year, at least the third wave that we were in the middle of almost when the budget was announced, it wasn't as severe in terms of our health systems. There weren't as many cases of hospitalizations, but to suddenly go from around 12,000 crores to zero is a bit of a puzzle. It was an opportunity, and like I said, there have been lots of money that has been set aside for this. This was an opportunity to use that package. And I remember when it was first announced, it was announced to be done in these phases where there were going to be multiple phases. First one, of course, dealing with the immediate short-term impact of the pandemic, which is what we did. But then also slowly, how do you ensure that you support prevention, you're prepared for the next health crisis, you've strengthened your disease surveillance systems, you've strengthened your community engagement, you've strengthened your national and health systems. And I think it was a little early to wind it up. Maybe it'll come up, maybe it'll show up somewhere else in the budget, but it's definitely not showing up in terms of the way that it was coming up last time. But I think we keep going back and round when we think about health investments. And every time I'm having a discussion with someone, it often boils down to, well, you're not really spending enough. And I think the 2015-16 CAG report had that stark number that in 15-16, 9,500 crores were lying unspent in the National Health Mission. And we've been, as you said, studying the data, and usually the absorptive capacity in the National Health Mission is about 60 to 70%. But I think that's where we do get stuck in a bit of a chicken and egg kind of situation, where often the lack of ability to spend is a reason to not allocate enough. But I think this is an opportunity to actually go back to the fundamentals. Part of the problem that I know you've also been studying, and so have we together, is the question of the CSS design. We know that states are incentivized to take money. And so even if you don't need the money, you would take it. And the way that the centrally sponsored schemes one-size-fits-all model works is that even a state like Kerala that doesn't really need a Janani Suraksha Yojana will be incentivized to take it if it gets that opportunity. Because why would you not take money that is being given to you and no one is going to say no? But unfortunately, we keep, in terms of the design failures, I think what we've seen repeatedly in NHM are 2-3 things. First, despite the fact that you've designed a program that had flexi pools that allowed you in theory to be able to spend across pools, you saw that they continue to get tied. And actually in practice, you can't really spend across flexi pools. And this centralization that happens often at the union level is again even translated at the state level. So we've been working in some states where for a district as well, if it needed to spend on anything, it needed state approvals for each and every item, to the minutest of, like, I need to spend on a bulb, I need to get approvals for that. At the same time, even the unspent money that is lying, even those require approvals. So here too, again, I felt like the pandemic was an opportunity. It did that in last year, which it kind of relaxed this flexi pool business. It allowed states to a large degree to be able to move across line items. This year, again, we're back, at least that's what the guidelines say, that we're back to going back to the slightly tied, rigid structure. We've also seen, apart from this entire approval process, we've also seen that partly possibly as a consequence of the approval process, that funds often come late. Again, COVID was an opportunity where you saw, especially for money that was linked to COVID, you saw this fast release, but that same fast release doesn't somehow get translated into the other components. And part of it comes back to this question of we're constantly trying to contract expenditure, and as a result of it, the social sector gets often the worst hit, where guidelines are given that you should not release money, you should slow down release of funds, and that again adds to this vicious cycle where you're not getting money, you're not getting it on time, you're not being able to spend it, and that of course impacts your next year's approval process. But what's also been interesting again with the National Health Mission, and partly again going back to this CSS design, is that when you look at it in per capita terms, the National Health Mission was designed, again, you had these high focus states that you are going to prioritize certain states which had the worst indicators. But when you start looking at it in terms of actual transfer of funds, there isn't that much variation. So a state like Kerala or a state like Bihar are getting roughly around the same money. And we did this a few years ago. And in fact, it was the reverse situation where states that had better capacity, partly because they had better capacity to utilize, better capacity to do their paperwork on time, were getting more grants. And that's almost contradictory to what the NHM by its design wanted to do or tried to do. So I did think that this budget could have been an opportunity to rethink the centrally sponsored schemes. We've seen across a large number of ministries, even this budget announced umbrella programs, attempts to try and restructure centrally sponsored schemes. But somehow we haven't done that with NRHM, and I was an NHM rather, and I was surprised, especially because like Mr. Sinha has said as well, COVID gave us ideas. COVID showed us that it's okay to be able to give this flexibility across flexi pools. It's okay that we can use that planning process to actually plan for something that we need. So it was amazing how fast we were able to come up with plans for COVID. We were able to action it out, and utilization for the COVID component of the National Health Mission was really high. It was around 99%, 100% almost across most states. But the non-COVID part, where we're back to the business as usual model, that's where utilization has been low and continues to be low. I'll end with one last aspect, and I think since you spoke about decentralization, I think we all spoke about decentralization. I think what's been fascinating, and again, looking at health financing a little bit more closely, is that there have been these attempts of coming up with different innovative programs. And the 15th Finance Commission, again, was useful because it brought back this idea of health grants, something that was attempted in the 12th and 13th Finance Commissions as well. But I am a little worried, and I saw a question in the chat question as well by Anurag, which is saying, well, it's turning up in the Ministry of Health and Family Welfare budget. Should we be worried? And I am a little worried. So far, I haven't been able to get my hands on the actual guidelines. The ones that came out in July said the ministry will be determining and creating guidelines for how these funds will be released and utilized. This was July last year. November, the money was released, but I haven't seen exactly how they're going to be utilized. And that is worrying because some of our past experiences have shown that when funds are released, especially to local governments, there is a tendency to add a number of conditionalities, even though the Finance Commission said that there shouldn't be. And that again goes back to some of the NHM problems that I spoke about, where lack of flexibility and lack of autonomy ends up also being a factor to not being able to spend your money broadly, but also spend it on the things that you necessarily need.
Thank you. Thanks, Avani, for that really comprehensive, detailed insight into both the details of the health budget, the complexities of expenditure. And I think you've highlighted in a very sort of detailed way the realities of what it takes to actually manage the centrally sponsored schemes dynamics, which have so much to do with the challenge of governance as well, and what the budget did and didn't do. We'll come back to some of these, and I am going to pick up from some of the questions from the Q&A box too through in this round. So please do put your questions in. I'm keeping an eye on them as well. Professor Reddy, let me come back to you. I think there's there are, on the one hand, there is a very critical policy question that a lot, has been raised through this sort of center-state discussion and the governance discussion that that we've had over the last few comments, and that is, given the challenges of governance and state capacity, does it make sense to think about union government health spending from the point of view of more equity, more in areas like where more investment is needed, but perhaps spending capacity is a challenge, versus efficiency of spending, more in areas where money can be, where perhaps the need is not as acute, but the efficiency of expenditure, bang for buck, is higher. And sort of related to that, how do we balance out? So you spoke in your opening remarks about a comprehensive, cohesive health system that touches upon every single aspect of health. But across states, the needs are quite varied. Yet when we think about it from a union government policy perspective, the one-size-fit-all sort of framework often means this year we'll focus on health insurance, next year we'll do a little bit more on national health mission, third year we go into infrastructure, fourth year we think about something else. And it's a consistent governance challenge that we've been dealing with for many, many decades. So how does one, if we really do want to move in that direction of comprehensive, cohesive, connected health system, what are the conditions under which one can ensure that we're investing in the right way in states such that those conditions get met? And that sort of relates to the equity versus efficiency question, which often also gets thrown up as a reason why we shouldn't invest more in health. If we don't have efficient spending, why put more money in? So your thoughts on that?
Firstly, as far as the question of why health is unable to utilize the money allocated, or why some states are less capable of utilizing it, I think unless we do some front-end spending to improve not only the infrastructure, but the human resource situation, and of course, give adequate equipment and supplies, we are unable to create a situation where the money allocated would be absorbed and utilized well. So that front-end spending is absolutely critical. Now, coming to the question of why we cannot utilize the money, I do not see why not. If you are really looking at primary health care, the one ASHA per village concept came in when we were looking only at maternal and child health, some elements of infectious diseases. And now with comprehensive primary health care, where Dr. Paul says that only 15% of the needs of primary healthcare were previously met, but comprehensive primary healthcare through health and wellness centers will actually meet the rest of the needs of primary healthcare. We are still sticking to one ASHA. Why are we not doubling the number of ASHAs? Why are we not doubling the number of auxiliary nurse midwives? Why are we not expanding our primary healthcare personnel at the front lines in order to meet the expanded agenda of comprehensive primary health care? Secondly, if many of the states which are underperforming are very short of doctors, we talk in terms of compulsory rural service and so on and so forth, but that rural service is also going to be confined only to the states which have a large number of medical colleges, and they will continue to have their own graduates coming into their rural services, whereas states which have low number of medical colleges are not going to benefit from that. Why not create for National Health Mission an additional component of short service commissions in which you actually create a national pool of doctors who can be employed and deployed across different states so that you can get much more equitable services. There are a number of solutions you can actually try to innovate for meeting the human resource shortages. Otherwise, the states which are already well-equipped and well-resourced will continue to show efficiency gains and will continue to get those additional resources, whereas underperforming states will continue to underperform. This is the so-called Matthew principle, in which to he who hath more shall be given, and from who hath not, what he has will be taken away. No, it's that kind of problem. So therefore, you have to definitely ensure that the center steps in to provide that level of equity, and after providing that equity, demand efficiency. Efficiency will not come without that level of equitable investment. And that is where I believe we ought to really focus on both, not just on the one. And I suppose that's the response you wanted from me. Is there any part of the question that I did not address?
No, I think you gave a comprehensive response. Let me just add one more question to you while we have you, that's coming in from our audiences as well, which is really asking for your for the panel's thoughts on this question of digitization, which is the National Digital Health Ecosystem, which is a very central part of the union government's focus. And as you mentioned, it found mention in the budget speech too. One of the questions that the audience is asking is whether the fact that we have a deep digital divide, which as COVID management has shown, is going to muddy the discourse on health investments. How do you see, should we be thinking about the process of digitization as creating enabling conditions? How do we bridge this gap of digital divides? Your thoughts on that?
Well, we have to take advantage of the digital technologies, and I don't think we should shun them, but we should utilize them again to ensure that we get both efficiency and equity. In terms of training a large number of frontline healthcare workers to become digitally enabled and comfortable in using them, it should not be too difficult. We have done that even from Public Health Foundation of India with health devices, with decision support systems embedded in them. And we have had very well demonstrated control of diabetes and hypertension by trained auxiliary nurse midwives in Himachal Pradesh and elsewhere. So it's not difficult at all to have digital technologies provided to frontline healthcare workers. But digital technologies by themselves will accentuate inequities if you do not invest in other elements of the health system. Then otherwise, then again, you will meet the same fate that those who are digitally comfortable or digitally equipped will utilize these technologies, but others will fall behind. And even if there are people in the sections of the population who are not comfortable with digital technologies at this moment, and if they are unable to access it on their own, then having the frontline health workers in primary care in urban and rural primary care, as well as community-based organizations, the NGOs, they can be actually the intermediaries. We are ignoring another vital resource that is available. So there can be a bridge element where the digital technologies can be brought to people who are not at the moment digitally comfortable to access the benefits of those technologies with that kind of helpful intermediation. So these are the kind of solutions we ought to find for making optimal and extensive use of digital technologies to benefit.
Thank you. Dr. Sinha, if I can turn to you, two questions. One is just too tempting not to ask you, since you've sort of framed the financing and governance interlinkages so well in your opening remarks. How does one get around this mission mode problem, that everything aligns when there's one target goal, but when the goal gets more diffused and more complex and we have to build a system around it, that's when the governance challenge becomes more acute. And a specific question that I'm going to pick up from the audience questions that I think we'd be very keen to hear your thoughts on, which is, what would you think are some of the public finance management reforms that are needed to enable more timely releases, more transparency, and better utilization?
Thank you for the two questions. Very clearly, what comes out when you do the across states, for example, Avani's concern about the poorer states not utilizing resources to the extent that many with better capacities did. So many a time in a program itself, for example, even with the health mission, there was a factor of 1.3 with which all allocations to the so-called the focus states was built in. But that did not make a difference, because by the end of the year, when you have monies to spend, but some of the states which need more money don't use it, you actually move it elsewhere. The other point, which I think is very significant in this entire public financing debate, is that, there's always this tussle between what I call the inertia of the mainstream and the innovations of the project. Now, mission mode are project modes. But the challenge in education is that you have to remove the inertia of mainstream also. Necessarily, you have to build your such a manner that the mainstream gets involved in the implementation fully. Create institutions which allow for flexible financing, which allow for innovations in human resource engagement, and so on. So the answer is that the PFMS, which is the tool currently to track expenditures, and which has been pointed out, many of the CGA reports have a lot of value because which actually allows you to track to the last point where the money is. Having said this, the getting more resources to underdeveloped regions, many programs, wherever you have a universal program, and again, this is to do with the socioeconomic census as well, where deprivation is the basis. You will see, for example, in the rural housing program, bulk of the housing units have gone into so-called backward states. The reason for it is that is where the large number of deprived households. Similarly, under the PMJ, deprived privation being from the social census, a very large number of the beneficiaries are in these states. The challenge is to reach them. And again, the point that Dr. Reddy mentioned, connecting households to health facilities, something which the ASHA was able to do for reproductive and child health. But for other sectors, we still have a long way to go. I think the issue of that you have highlighted in the first point, besides the public finance challenges, is the challenge of allocative as also the mission mode, kind of grappling mainstream. I think this is where the decentralization thrust of the panchayats and panchayat system and their involvement, institution level autonomy. I think if these goals are pursued, and this is what the health mission also tried to do, this is what the health and wellness centers are also trying to do, to enlarge the scope of a facility with the flexibility to actually meet the needs at the local level. Because devolution with financial devolution is inadequate, because ask for a certain guarantee only come if there is flexibility at the delivery point. And I think this is where the challenge is. So there are major challenges. Many institutional reforms have been attempted over the years, but clearly there's a long way to go. But what comes out with the experience of the ASHA program is how demand-side financing does make a difference. How that's why even for the digital debate that is going on, technology has helped us on for getting ensured it doesn't become ubiquitous in any manner. It's important to focus on, to first understand that it is a means to an end, and that too, connecting the households to the facilities becomes very, very important. Whatever we do, and facilitation is needed there. It will not happen by itself, either through the frontline worker or some other means, unless and until we are able to do that. So some of these challenges will remain. I think these are some of the points that I could take from your questions.
Thank you. Thank you so much. Ms. Kapur, let me come to you both, your insights on the public finance management question. But there's also another very crucial question on an issue that you've worked on quite a bit, which is on nutrition financing, specifically around the question of whether declining investments in nutrition financing ought not to get center stage in our debates on health, especially against the backdrop of a more broader view, as Professor Reddy pointed out, that the government is beginning to take on health, looking at its social determinants, drinking water, etc. So your thoughts on that as well.
Thanks, Yamini. So let's start with the second one first. I think that it's shocking that nutrition has taken such little priority in the country, especially given we were really hopeful. We got into nutrition financing around 2017, and that was a year where there was a lot of push. There were the Poshan Abhiyan was launched. There was a commitment to say that supplementary nutrition costs will be finally indexed to inflation from 2017 onwards. There was this umbrella program again that was launched recently. So there has been a lot of talk about nutrition. And I think finally when nutrition got political priority, some of us who've been looking at nutrition financing were really pleased. But the numbers don't add up. And again, it is surprising that nutrition tends to be such an underreported component. So I do get that in a 90-minute budget speech, you can't focus on everything. But as everyone said, nutrition is the cornerstone of where even health starts. It is the starting point. It is the one that is actually impacted by all other sectors, or a large number of sectors that are nutrition sensitive. And the numbers have been really worrying. We've been trying to, let me give you an example. The ICDS scheme, previously called ICDS scheme, now integrated into one of the umbrella programs. It's a universal program. It's meant anyone who demands or wants to avail services is allowed to avail them. But budgets tend to be very, very significantly low. And we've been doing some costing work of trying to estimate. The budgets are around between 40 and 50% of the required costs. If you had to look at it in terms of covering every single person in that particular age group. And what happens on the ground again is that some amount of rationing happens. We've seen this in a state, I won't name the state, where actual limits have been put in terms of who can avail ICDS services. So they've got a quota almost. And so if you make that list, great, you'll get your supplementary nutrition and ration, you will get your child into preschool education. But if you don't, well, sorry, you'll be on the waiting list. That's shocking given that we have the National Food Security Act, which has said and made this mandatory as well. So the fact that nutrition, while getting a lot of political push, which has been great, somehow the budgetary outlays don't add up. Even last year, when I think the finance minister spoke about health as a far more holistic sector, she actually spoke of nutrition within it. She only referred to, if you look at the breakup of the allocations, she only referred to one component of the nutrition, which is much more the convergence program and the real-time monitoring system, which is the Poshan Abhiyan, rather than nutrition, which is, rather than things like ICDS, which has actually been one of the biggest schemes related to nutrition. So definitely, it is worrying that nutrition doesn't get the same kind of financial attention, and we are way behind than we need to be, and it will have an impact on our health sector going forward. On public finance, I have such a long wish list that I'll try and keep it short. I think, first of all, I think visibility on finances. As Dr. Sinha said, we now technically have the ability to know unspent balances lying in every single bank account. Who's actually using that information? Unfortunately, many of our conversations, that information isn't really used in decision making. So when you have to utilize 60% of your budget as a state to be able to get your next installment, that 60% is an average across all facilities. There'll be facilities that have spent all their money, there'll be those that haven't. Are we actually getting that glimpse of our finances and using it to be able to make decisions saying, well, if you don't have the absorptive capacity, you don't have the junior engineers, you don't have the specialists, let's not send you money there. But others that can spend it should be sent that money. I think we have that ability again. We know that you can send money really fast, but I think partly because you don't want to block it in bank accounts, you tend to withhold funds. That's again an easy fix. If you are able to create this form of just-in-time system where you have that visibility, you're able to actually pull money when you need it rather than wait for the entire state to reach a certain expenditure threshold. The last one, like I said, I have a long list, but I'll stop here. I think from the ability to actually lessen the administrative burden. Again, the PFMS system, we've seen how UCs can be automatically generated. We've seen there are all these other aspects that can happen. Unfortunately, we've not utilized that enough. We're still the notepad. As much as we talk about digital, we like that piece of paper that looks like a utilization certificate. And I think here I'm looking forward to using some form of digital technology to create e-paper opportunities across all states and even across the union government.
Thanks. So we actually have a set of prescriptions that now can be moved to at least ensure that the basic 101 of governance, moving money, can work in a more transparent way. Professor Reddy, I'll come back to you. There's a couple of questions, one that is specifically directed to you on the public health cadre that you brought up, asking whether a public health cadre, given that there's not been that much movement with the public health cadre, what's your view on developing a sector-specific, even within health, so a public health cadre for nursing, nutrition, as areas of education and practice in the country? There's another issue that I was keen to get your view on, which is, this whole issue of public-private partnerships repeatedly comes up, especially when we talk about the challenges of financing and government and governance in health, public health provisioning. So, how do you see the opportunities and limits of private sector in our debates on the health system?
Well, as far as the public health cadre is concerned, there has been almost a policy commitment to have a public health cadre in every single state. That has not moved well far beyond because of a variety of reasons, partly because governments have not been very keen to take on the established medical associations and so on, and because there is a concern that public health cadres could be open to non-medical people, and that can be an area of conflict. On the other hand, Tamil Nadu and now Odisha have started public health cadre within the medically trained people and are taking in non-medically trained people through contractual employment in the various national programs. So somewhere the states can begin and the models should be adopted. But that's not going to happen unless the center really starts incentivizing them. But to your question as to whether you can actually create public health sub-cadres within the medical cadre, within the nursing cadre, and even possibly dental public health, yes, there is certainly a great opportunity to do that. Each one of these professions can benefit substantially from public health exposure, which is across the cadre, but with a certain level of specialization in public health within the cadre. So I think that is something that can be done, and the center should really start thinking about it. Regarding public-private partnerships, given the fact that we do have a mixed health system which is evolved by default rather than by design, but we still have to optimally utilize all the resources we have, public, private, and voluntary sectors that exist. Unless you create a very clear-cut roadmap for universal health coverage, in which the public sector is strengthened and plays the critical lead role, in which the private sector is contracted and becomes a partner to fit into the overall architecture of universal health coverage with clearly defined deliverables and accountability mechanisms, we are going to still see disconnected elements of our health system. So that is where, again, you need to bring in a structure where you have networks of providers at each level of care, primary, secondary, and tertiary. And you need those networks to be connected across the levels of care. And those networks actually can start delivering, and where this district by district, you can decide where the resources have to be drawn from the private sector or not necessarily to be drawn because the public sector is strong enough. But you have to ultimately move towards a capitation fee mode of payment and a single payer system. And unless you bring the private sector under the fold of universal health coverage with very clearly defined architecture, you're not going to see that. You're still going to see disconnects if you're only going to be contracting them periodically and then expecting them to deliver the services. They have, like in the United Kingdom, the National Health Service has the GPs who are actually private providers, but they're all contracted. They work within the system. So let us create an architecture of a single risk pool with a capitation fee mode of payment and have different networks delivering these services. And we can bring the private sector in as per need and opportunity in a more coherent manner, rather than expecting them to deliver services sporadically. And as we have seen in COVID, it's not always happened either with efficiency or with equity.
That's at the heart of the challenge in so many ways, the efficiency and equity argument, which brings me to one last piece that I don't think we've discussed much. I know we're coming towards the end of our discussion. Dr. Sinha, if you could reflect a little bit on the two things. One, this lack of human resources, consistent vacancies. It's not a new story. This is not a COVID story. It's been a very consistent challenge with the health system. Some of it is about lack of resources, but there's also a question around the processes and dynamics and incentive structures for filling these positions. So just wanted to understand a little bit better, what are the bottlenecks? And related in that sense, given that now local governments have a much greater pool of resources, could that be an opportunity to genuinely devolve certain public health functions and functionaries, crucially, to local governments so that we can ensure the local accountability dynamic actually works? What are your thoughts on that?
No, I think in any sector or nutrition, which actually follows government where it is to kind of partition it into one department. It doesn't lend itself to narrow department. These are ideal candidates for the panchayat as a leader, because if at that level, the 29 sectors in rural or the 18 in urban, which is what the 11th and the 12th schedule talked about, if we are able to work on them simultaneously, one major issue is that it can leverage resources. The other point which comes out is that we have seen, for example, if historically 2005 onwards and now, and the NFH's results, which are, what does it indicate? It indicates that if there is a clear thrust and focus, there is a resolution of the last mile challenges. There is absolutely, a very categorical understanding in a system that these have to move forward. There is movement there. I think I'm raising this issue because 2005 onwards, if I compare, say, 1990s to 2005, on many parameters, especially with regard to infant mortality, maternal mortality, the reproductive and child health parameters, there has been a movement forward. It can be faster, but if you start getting into the details of it, what you find is states which have invested in the frontline teams more effectively, and also in providing guaranteed services at subdivisional, district, and block hospitals. These are the states which seem to be moving up much faster. Besides the usual champions that we've had in the past, Tamil Nadu and a few other states where this health system was always very strong, the public health cadre is there. We now have quite a few states where at least it's possible to provide a service with some, and that's where the human resource matters a lot. So I think sensitization to human resource as a challenge has been there all the while. The response has been mixed. The systems of recruitment, of certification challenges there. Having said that, there is no from it. And will have to actually build primary health capacity through a team of health workers, a continuum of healthcare who actually provide the services that are needed, whether it is diagnostic services, whether it is OT assistants, whether it is lab technicians, whether it is staff nurses, whole lot of major requirements which have to be prioritized if we really want to make the system, because what happens often is these are the more difficult areas. We end up building or creating the equipment, but the actual human resource to man it and manage it is where the challenge is. Having said this, the experiences across states is mixed. There are many states which prioritize this and have been able to get better results. But I think what comes out very clearly is that even a slight movement in terms of financing and in terms of governance improvements or in terms of responsiveness of the system, the results become a little better. So I think this is what the lesson is, that, besides the financing, which is important, we also need to work, which is very, very important, the governance bit. And I think from that perspective, if I look at the NFHS 5 data, a lot of what comes out is, whether it is to do a lot of the mobilization, the social capital at the local level, for example, besides the panchayats, the self-help groups, states where the livelihood mission and self-help groups are strong, there also we see interlinkages and cross connections. So, many of these programs which need a strong community base, decentralization, centrality of panchayat, responsibilities to panchayats, and leveraging resources through this process will actually strengthen our capacities and capabilities at the local level. And it will also improve our accountability in the long run, because unless and until we do that, any amount of just setting up a system without the community connect, without the household to health facility connect, there will be challenges. Thank you.
We're all out of time, but before we close, I'm going to ask one quick 2-second question to each one of you, starting with Ms. Kapur. If you had to plan from today for next year's budget, what's the one ask you would have of the finance minister? At this point, the world is open. So.
I think since we were talking about local governments, I think this is definitely an opportunity to actually invest in local governments. And not just from a health perspective, but also we know that panchayats have been both panchayats and urban local bodies have been underrepresented, and they are the place where citizens go. It's the place where the citizens have most amount of trust in some ways, and that's where a lot of the services converge. So bottom up strengthening is where I'm headed.
Professor Reddy, your one ask of the finance minister so she can plan for the year for February 1st, 2023. You're on mute.
Invest in both urban and rural primary care, but with a strong community monitoring.
Thank you. And Dr. Sinha, last word to you. How should the FM think for this year so she can make a grand announcement for health in February 2023?
Whole of government, whole of society, decentralized management of health with panchayats and urban local bodies is the critical thing. What has worked in stepping up, augmenting COVID services or vaccination, the lesson is clear that unless and until these things that I mentioned, the whole of government, the whole of society, and along with HR challenges which I mentioned, the decentralization, panchayat and their centrality.
Thank you. We started with a discussion on the union budget, and we closed with a discussion on the centrality of the community, the local governments, a whole of government approach, urban to rural, and an investment in primary health, all of which points to how central people are to the debate on the budget, which in conversations on fiscal deficits and capital expenditure often gets lost. So thank you very, very much to all of you for making the time for this really important conversation, putting health front and center, and putting your wish list out for February 2023, when I hope we can come back to discuss the budget threadbare, this time to say, the Citizens Commission's sort of plans for a citizens budget were actually accepted and reflected in the budget. We can always hope. Thank you, Professor Reddy. Thank you, Dr. Sinha. Thank you, Ms. Kapur, and thanks to the audience. Look forward to seeing you at our next webinar next month. Thanks.
Thank you very much.